So here at the EHA 2023, I had this lovely discussion with Professor Facon on a session that was chaired by Professor Rodriguez Otero, trying to discuss the optimal duration of myeloma therapy. So I think, is the ultimate, pendulum analogy, right? There was a time in myeloma where therapy was fixed duration. And I think in the last 10 years, we really moved towards embracing continuous therapy, in great part due to studies like the first study in non-transplant eligible patients that determined the benefit of ongoing Lindax versus fixed duration Lindax or a melphalan-based therapy. But also in the transplant eligible setting, a series of trials that have been aggregated in a meta-analysis showing that continuous therapy has progression-free survival and overall survival advantage. That being said, I think now there's a tendency, a lot of that driven by patient requests, patient's desire, and also the improvement of upfront therapies to start to question the paradigm and move away from continuous therapy. And I think data such as the success of quadruplet therapy with transplant, with many patients achieving and maintaining MRD negative even without further maintenance, I think helps to support that. So the answer is we don't all have the optimal duration. It's probably not a right answer for the same answer for everybody, but it was very clear that on the audience there was a desire to do that. And I think what is coming in the future is as we start employing therapies such as CAR T-cell therapy, and we saw at this meeting the results of the CARTITUDE-4 with excellent outcome for patients receiving cilta-cel in 1 to 3 prior lines of therapy, as well as the huge interest in the field of fixed duration bispecific antibodies. I think the fixed duration approach is going to have a great revival.